Welcome to Thriving in Our 40s. And today we are in for a treat because not only do we have one guest, but we have two. I am delighted to welcome Dr. Sharma and Dr. Wright to Thriving in Our 40s, both menopause specialists. Together, they run their online menopause clinic called Spiced Pear Health. So, welcome, Dr. Sharma and Dr. Wright, to the podcast.
Thank
Hi,
you for
nice to
having
meet
me.
you.
It's really lovely to have you here. And I know you are very, very busy. We're having a chat behind the scenes about what's been going on. I really value your time. And as menopause specialists, there's no guesses what we're going to be talking about. Yes, we're going to be talking about the menopause today. But what I really hope this episode to be about is to be almost a menopause 101 for people who have the questions, but not the answers to everything that is affecting us around menopause during midlife, HRT, mental health, sex, PMDD, the list goes on. And so there's going to be lots to talk about. And the questions that I have today, and there are quite a few, they've all come from listeners. So the response has been phenomenal while I've been telling people that you were going to come on. So we're going to work through some of the questions. And then if anyone has any questions that they want to ask you, in a more personal setting, then they can come to you through your platform, Spice Pear Health. Does that sound okay?
Sounds perfect.
Wonderful. Right. So we're gonna kick off. Maybe Dr. Wright, we'll start with you first. A really broad question, but I think it's important to set the tone. What is menopause, and how do we know that we're going through it?
Okay, how long have you got? So this is
Top line, top line.
Cool. I mean, menopause, the word refers to your last period. So usually we say it's a diagnosis that you can only make in hindsight safely. You need to have gone through 12 months without bleeds in order for us to say that you've gone through menopause. But what most people are talking about when they talk about menopause is the broader transition period when you get to the end of your reproductive life, and that regulation of periods and ovulation gets a bit more skew-if, and women tend to experience lots of symptoms related to fluctuating hormone levels. That refers to what you'd say in inverted commas a natural menopause, but there's also a lot of women who go through different forms of menopause.
Mhm.
So if you have surgery and have your ovaries removed, if you go through cancer treatment, for example, and your ovaries are damaged by the treatment process, you can have an induced menopause or a surgical menopause, or there are women who go through this process much earlier in life who have specific symptoms that relate to the difficulties, the additional sort of consequences of losing their hormones in their 20s or their 30s. So we're all talking about the same subject, and some of the long-term health implications are the same regardless of the cause, but the process can be quite different for people.
I think that's the thing, isn't it, Dr. Wright? It is so nuanced and it is deeply, deeply personal. And we're going to get on and talk about crash menopause. 'Cause I know that is something that's a really important topic that I knew nothing about until I started researching for this conversation. So we will get on to that, definitely. If we're talking more about a natural menopause, though, and maybe Dr. Sharma, I could hear from you in this respect, what are the obvious signs that, we are approaching menopause?
I think the first thing to say about that is everyone's different,
True.
and everyone will have different symptoms and a very unique experience. But usually the first thing that people feel is some changes in their periods, like the cycle might be slightly longer, or it might be slightly shorter. The periods might be heavier, or they might be lighter. Basically, anything can happen to your periods, and with it, then you may get some other sort of symptoms of the fluctuating estrogen starting to go a bit up and down. So the symptoms may be on and off. So you may have like one symptom, or you may have a couple of symptoms, and then you may feel fine again. So that's why it's really hard. Like, for example, you may have like a worsening of your migraines, and that might be the only symptom that you have at the beginning. And so, you might go to your GP, and instead of picking up that it may be perimenopause, they'll be giving you some tablets to help manage your migraines. And then a couple of weeks later, you may be coming in and, I'm feeling a bit down, I'm feeling a bit depressed. Another day, you may be saying, I've got joint pains. It's sometimes really hard because you want all of these symptoms to come together really nice, but they don't come together nicely packaged with the word perimenopause on top of them. So I think, there's multiple symptoms throughout the body. There's in the brain, it's brain fog, changes in mood, irritability, changes in temperature control, so hot flushes, night sweats. You've got also weight gain around the middle. You've got people with joint pains and aches. So that stiffness, when they wake up in the morning, they feel like they've aged overnight. It's not really just one joint that's hurting. It's a full body thing. And then in the pelvic floor, vulval, vaginal, bladder area, you've got a huge number of receptors. Although the symptoms may not appear at the beginning, at some point they will come, and it will be things like vaginal dryness, pain during intercourse. You may get recurrent urine infections, so this is where prolapse is, and everything starts to get a bit loose and fall down, and then all the sexual symptoms as well. That low desire, you get reduced arousal, because of the reduced sensitivity of the nerves, and because your pelvic floor is a bit loose, then it doesn't contract as well, so your orgasms become a bit weaker. So multiple systems in the body, and I'm sure there's like every time we look at a list, there'll be more and more and more added. It's kind of like a huge number of symptoms, but just remember that they may come one at a time, and they may not all come together. So just if you're starting to feel a little bit off, and you don't feel like yourself and feel like something's changed and something's different, then start noting these symptoms down. And it
Exactly.
might be better to monitor for a couple of weeks and then maybe go to your GP, but make sure you tell them about all the symptoms, and also make sure you tell them how it impacts you in your day-to-day life, because then
Yeah.
that really puts all the symptoms in context, rather than, as GPs, we get like so many people just giving us symptoms, and it's really hard without knowing how that fits in someone's life. So,
That's so
yeah, just
helpful
a
because
little tip about how to talk to your GP. Yeah.
well, that is going to be my exact next question, because the more I've
Okay.
been reading around this, the women that just get sidelined, like you said, if they go about a migraine or being depressed or, aches and pains, time is precious, for everyone. And so I feel from a personal perspective, when you go and see a GP, you want to do it quickly. Don't want to waste anyone's time. You almost feel apologetic for going in the first place. However, it's really vitally important that each individual woman gets the right treatment. So, Dr. Wright, as a GP, but also as a woman, what is the conversation that we should be having when we go and see a professional about our health?
It's a good question, because I think the situation that we're in currently doesn't suit the practitioner or the patient. We're trained to do a much better job than we're able to access in 10 minutes under, extreme pressure within the surgery setting. And I suppose what helps us is to have some clarity about what's being brought in. So, as Angela says, when someone's had a chance to collect their thoughts and maybe has made some notes about what's been going on, has already been able to kind of collate a little bit about the picture, so it's clear, that helps to make the most use of the time that's there. I actually think it's helpful if you think you're in perimenopause, and if you have, come across a symptom checker. I actually find that helpful, because I think that it allows patients to have done some of the thinking around what they think might be going on for them, and it allows the practitioner, if they're not experienced in menopause, to be given a hint about what the conversation is going to be about. Because one of the biggest challenges is it's a really mixed bag out there. There are some really well trained, really thoughtful, women's health aware doctors who will pick this up straight away and give you good service. But there's also a lot of doctors who won't have had very good training. I'm speaking for myself. I had very little training in this subject before I did my additional training. So I wouldn't have been a very good practitioner in this area until I did my BMS menopause training, because my previous training didn't really cover it. So you're sometimes talking to somebody who doesn't really understand the area, and it's quite difficult as a doctor still, I think, to admit to not knowing things. And so you tend to go to, well, I know about depression and I know about migraines and I know how to treat joint pain, and you might miss the bit in the middle. So it actually helps us if you come in and say what you think is going on, and it helps to be aware of guidelines. One of the things that Andrew and I often say is, if you don't have a good experience with a GP, you are able to vote with your feet and go and see another GP within your practice. And in most NHS practices, one of the doctors is doing most of the women's health work. And if you ask at the school gates, at the gym, amongst your friends, most of the time those doctors get well known in a community. And it can be helpful to sort of select. Angela in Notting Hill is well known for being the doctor that deals with. When I was working in Mass, and we had patients join the practice because they knew that there was a menopause doctor working within the practice. So pick your GP, do your research, be clear in your head about how you want to use your time and the question you're asking. Are you asking to go on to HRT? Are you asking for a referral? Are you asking about urinary symptoms? Try and be clear about
Yeah.
what it is that you want. But if it doesn't go well, and I think we have to accept that sometimes it doesn't, because there's a massive problem with training within this sort of this specific part of women's health within the NHS. Still, it's getting better, but there's still a big gap. Don't give up at that point. Do some local research, find out if somebody else is better at this, and try again, because the help is out there.
Absolutely. One of the questions that has come in, and maybe either of you could answer this, is about the Dutch test and whether you can
Mm.
take a blood test to find out what's going on hormonally. Could you give some clarity on what that involves and whether
Yeah,
that is something that people can go on and do?
Do you want
yeah.
to
I
say?
think it's really interesting because every single woman that comes to us privately as well and NHS will want to have some kind of testing, some kind of confirmation that they're going through perimenopause, and that's the problem. Is then it's the nature of perimenopause is that your hormone levels are fluctuating, and whenever you do any kind of test, it's that moment in time. And invariably what happens, and this is what happens, and lots of GPs will do these tests for their women, and then tests come back normal, and then you've got this woman in front of you who's got all of these symptoms, and what most people will say to them is there's nothing wrong with your hormones, off you go, and then they're completely lost, and then they get dismissed, and they know, and women are very, very good at this, they know when there's something not right with their bodies, and then they get told, and this is that gaslighting or the dismissal or the, but you have to understand that that's the wrong question to ask for your GP. And you know it's very, very clear, the guidance is very, very clear that we don't base perimenopause on blood tests or Dutch tests. I'll tell you about that in a minute, but we base it on symptoms. And that's why a symptom diary or noticing what's different or having a look, as Angela said, like the questionnaires, with all the symptoms on them. And, just monitoring for a couple of weeks, even a couple of months, just seeing what's different and how things have changed. All these, are so many apps now you can download, to monitor your menstrual cycle as well. Just start using all of these things. Just become more focused on yourself and on your health, because, we're always looking after everybody else. We know our health becomes low priority. So it's just kind of reversing that. In terms of tests, there are some people that may need tests, and these will be the women that are usually below the age of 45, or even below 40, like some women will come with these symptoms. And the reason why I would do blood tests with them is just because you're trying to, it's a little bit earlier, not saying that some women wouldn't start their menopause at that age, but you just want to really make sure that you're not missing something else.
Okay.
I'd also jump in and say that I've had these conversations with patients where the main focus of what I'm trying to say is, yes, on that day at that time, the picture that you had was that your estrogen was really high and your progesterone was very low. But what we know from the conventional evidence is that that picture is going to change over hours, days, and weeks. And so
Yeah.
if you build a treatment regime around saying, oh, you're progesterone deficient, so what you need is progesterone, you're building a treatment regime around maybe one or two snapshots in time. So I often think alternative medicine and some of the fringe stuff ultimately does have something to teach us. And we've both been doing this job long enough that we've seen things move from the fringe, get a good evidence base, and
Mhm.
become evidence-based medicine. So I never want to dismiss anything out of
Yeah,
hand. But at the moment, there's no clear evidence that following the specifics of what's happening on one blood test is a beneficial thing to do in terms of general care. And we do know the hormones fluctuate all over the shop in peri, which is the challenge.
absolutely. It is definitely a challenge. But like you say, if you can keep a symptoms diary, then that should help to eliminate or steer everyone in the right direction. Can I talk about HRT now? I think this is obviously a huge topic. It receives much curiosity and much controversy as well. Um, Either of you could answer the first question. What is HRT and why is it recommended for perimenopause?
Do you want me to take this first
Yeah,
one,
yeah,
Andy?
we'll do it one by one.
Yeah, off we go then.
So, I mean, actually, even the terminology is starting to shift. In other parts of the world, they're talking about hormone therapy or menopausal hormone therapy, so MHT or HT, because this idea that we are replacing something that we're deficient in is quite a controversial idea. This is a normal stage. If you go through menopause in midlife, this is a normal physiological transition with consequences, but it's not a deficiency as such in the minds of most of the international societies. If you're younger, then you are more deficient and you do need to be replaced up to the natural age of menopause. So you've already got that sort of division, which is if you've gone early, generally the evidence base is that we would advise you to go on to HRT. You're in a different situation where you're prematurely deprived of hormones that are important for bone health and brain health and heart health. And we've got an evidence base that says that without those hormones, your health is going to be suffering consequences. So in that group of women with premature ovarian insufficiency, we would advise that those hormones are replaced. For the bigger group of women who are going through a midlife transition around their sort of, late 40s, early 50s, then there's a choice to be made around whether or not you want to prolong the number of years that you're exposed to hormones, use them for symptom control primarily, which is still the main indication to go on to HRT. The primary reason that you're supposed to do that if you go into menopause at the standard natural age is because you're thinking about symptom control in the main, so hot flushes, sleep, mood, that kind of stuff. And then you consider the secondary benefits you get from HRT, which are around longer term outcomes, particularly with bones and heart health and so on. We think that there are some benefits. But this is what's become, I think, a bit of a battleground in Angela's smiling. Oh, we didn't go into this knowing it was going to be such a controversial area. Become a bit of a battleground because there are bigger questions, I think, to answer about how much do we do the preventative healthcare aspect of thinking about hormones. But at the moment, the evidence base is quite clear that the primary reason that we should think about HRT is to treat symptoms of menopause, including things like loss of bone in osteoporotic individuals. But we think about symptoms of menopause and we use all sorts of different products. So we can use gels, sprays, patches, tablets. There's even implants that exist that basically put back the hormones that you used to create in your ovaries before they stopped working. So estrogen, progesterone if you've got a uterus, and we can go into more detail about that in a second. And sometimes we will augment testosterone. So that's broadly what HRT is.
Okay. Well done.
Subject.
It's huge, isn't it? It's absolutely huge. Is it something that you recommend at your practice?
Yeah, frequently. We prescribe a lot of it. And I broadly speak, if you're a symptomatic woman with a average or low risk profile, more than likely HRT is going to do you more good than harm if you want it. So you don't have to manage this transition with this. And there are lots of women who don't want to, and that's fine. And you can, like Angela says, you can do a pit stop, look at your general health and focus on other ways of keeping your heart healthy, keeping your bones healthy. We deal with a lot of women who go through cancer for whom HRT isn't available to them. And that predominant narrative of the only way to do this healthily is HRT is really harmful to that group. There's more than one way to do this.
Yeah.
But if you want to, and if you're struggling and, if your risks are moderate or low, then there's no reason that you shouldn't take HRT, and the evidence base would support.
Okay. Dr.
I think
Sharma,
it's really important. I was just going to say that it was really important to make sure that women know about all the options as well. And then they're absolutely, if they understand like the implications of each doing something and not doing something else, and then they can make the right decision about how they want to manage their own menopause.
and how long, Dr. Sharma, is it safe to be on HRT for? If you started, let's say, in your mid-40s, is there a timeline that we should be working with?
Yeah. I think if it's someone in your mid 40s, then you really want to be taking your HRT to the natural age of menopause, which would be 50, 51. And then after that, you can think this is especially for those women below the age of 40 who start their menopause early. The advice is to take HRT till the natural age of menopause. And then after that, it's a personal decision whether you carry on with it or not. If you're going through a natural menopause, there's no cut-off limit to say you can only be on HRT for this length of time. The HRT that we have now is much safer and it's much lower doses. It's through the skin, so it's less risky. So there's no cut-off period. I would suggest an annual review with your doctor. Just always ask the question, always ask women to ask the question, why am I taking HRT? Just so they're really clear for themselves why they're on it. And I think when you get a little bit older, maybe towards, if you're still on it, towards 60 or beyond, then you really need to know why you're on it, because you're in a different sort of category in terms of breast cancer risk. So breast cancer risk over the age of 60 rises, but just because of age, not because of the HRTs. If
Interesting.
you are taking it, you've got to have absolutely really clear reasons. And for most women, it will be because of symptom control, because their quality of life is so poor without it.
Absolutely.
Obviously, there may be some women who take it just because they never want to come off HRT. And I do have women in their 60s, 70s, 80s even still on it, and they won't come off it. But that's their decision. But as long as they understand the risk, and as long as they're up to date with their mammograms, and they let me know that if there's any problems in their breasts or anything, and I'm act on it straight away. So
It's
but
personal
it's a
again.
discussion. It's a discussion you've got to have with someone, and
Yeah.
every woman's going to be different. There'll be some women that don't want to be on it long term, and they'll just absolutely like, I just want it for a couple of years and I'm coming off it.
Yeah.
Or they might have
And then
osteoporosis and want to stay on it.
they might say, yeah, exactly.
This is it.
Can,
A question that I
can I add
have.
one?
Oh, sorry.
I was only going to add one thing. So I'm just aware of that kind of the social media narrative that certain forms of HRT are absolutely safe and carry no risk. And, if you're on body identical, that goes on forever. I just think it's probably worth pointing out that the evidence base that we've got for body identical HRT, the kinds that are the same substances that our own bodies make, is really limited to data around sort of 5 to 7 years that it's breast neutral, that it doesn't have an impact on breast risk. So for people who may be getting their information from lots of different sources and thinking, why would you not stay on it forever? And that's what some people are saying to do. The evidence we've got suggests that the natural form of progesterone is better in terms of breast risk and doesn't seem to carry the same breast risk as some of the older types. But that data at the moment is limited in terms of how far forward it stretches. We don't know that that's still the same after 10 years or 15. We can extrapolate maybe, but we don't know, which is why you get this slightly more cautious approach when you follow guidelines, which says you've always got to keep checking in. What's this lady's breast risk? But also, what's her bone health like? What's her heart health like? What's it doing in terms of her lifestyle? Does she need it for her sex life? And you just do this weighing up with every individual. But I
And
think
everyone's going to be different as well. And that's why it's hard to make sweeping statements about
Yeah.
HRT. And we always get nervous, don't we, Angela, when people ask us specific questions about it, and it's really difficult without all of that information.
an individual.
Absolutely.
And about an individual, yeah.
I think you've raised a really valid point about social media. In the build up to having this conversation, I was obviously doing lots of research, and my algorithms were just throwing kind of menopause reels at me. And there is obviously so much information out there, but you have to be really, really careful. And this is why I'm so honored to have you guys on, because we've got people talking from the professional side. And yes, you need to have people's personal stories and the case studies, that's very important, but you need to also have the scientific facts behind those as well. One of the questions that we had is, a woman got in touch and said, is there any benefit to starting low dose estrogen even when you're not in perimenopause to ease the transition into perimenopause?
I would always ask someone, what are you doing in terms of lifestyle first? And when you're very early on in perimenopause, that's really what you want to focus on, because this is what's going to keep you healthy in the long term and keep you healthy as you age. And this is where a lot of women take HRT, but they don't look at their diet, they don't exercise. And so those symptoms don't always get better. And I think it's really, really important to use it as a pit stop to really take a good look at your diet. What are you eating? How can you make this better? And how am I exercising? And the other huge thing to take control of is, how am I managing stress? And we
Mm,
know that women, we're in this period of time in perimenopause, you're juggling kids. I've got my teenage kids. We were just talking about,
mm,
you've got work commitments, you've got, trying to keep up your social life, trying to juggle elderly parents. There's so many things going on, and you have to keep yourself really healthy to manage all
mhm.
of those things and to keep doing that. And like I said before, women are always prioritizing everybody else before themselves. And if you don't manage that stress or find some way to manage that stress in your life, then even on HRT, you're still not
True.
going to feel good. So
Yeah.
for me, I would say think about those things first. And then if you're trying all those things and you're still having symptoms and they're impacting your day-to-day life, then I would think about taking HRT.
That's really sound
But every
advice.
woman's different again.
Yeah.
Every woman's different again. Some women
Exactly.
have one hot flush and they can't cope with it. And some women have hot flushes all day and it doesn't really bother them. So it's again about every woman and respecting like how. That's why that question about how does that impact you in your day-to-day life, and it's something that's then I can't juggle my life. I can't go to work. I'm struggling with my relationships, or I'm shouting at my kids and they don't love me anymore. It's all, you have to put all of those things into context. And then for that woman, then having a couple of hot flushes and a little bit of low mood and irritability is devastating because it's impacting so many places in her life.
Mm,
Whereas someone says, "Oh no, I'm fine. I'm able to sleep, go to work still." Maybe you can carry on and do a bit more lifestyle stuff, and
absolutely.
see how the symptoms go. Yeah.
More of a
Can
holistic
I
approach.
just hop in and say the question, as I understood it, was: is there evidence that it's beneficial as well to
Mm,
start early rather than starting late? And I just wonder if it's worth talking to that as well, which is, I get that a lot, that I have some patients who kind of, it's a very female thing, isn't it? They want to hang on and grit their teeth until it's really terrible. And they absolutely have the justification to take this. Because again, those narratives about, oh, just have a green smoothie and try and do a bit more meditation and it's all going to feel better. They can feel almost like another way to punish yourself. There is real truth in that. I've just got back off holiday and my resting heart rate was 14 beats lower without the stress of my working week than it is when
wow.
I'm at home. So
Wow.
stress is definitely relevant for all of us. But sometimes when you receive that on your thread, it's like another stick to beat yourself with. Oh, great, I
Mm,
haven't got up and meditated this morning. I haven't done my mindfulness. And it can feel like you're
That's
meant
not
to.
right.
Exactly.
It's
So
very important to do.
so I guess the question is, we don't actually know the optimum stage to start your HRT. There is no data that I'm aware of, Angela might correct me, that says if you're a woman going through perimenopause and your last period's going to be 51, do you do better starting at 45 or do you do better starting at 48? We don't have that data. So I think it's that. Is it impacting you? Do you feel like you're struggling? If you do, and if HRT helps, take the HRT.
yeah,
But it's not
sure.
health replacement therapy. It doesn't do everything
Yeah,
else for you.
yeah.
And if you don't look after everything else, you're sticking a sticking plaster on, but you're not looking after the lifestyle that might be making it all much more tricky for you. So yeah, it's never either or. It's kind of
No,
also
it's never
and.
cutthroat.
Yeah.
Yeah. We're going to move on to another topic very quickly, but I just want to bring up the Marina coil. Because obviously one of the clear signs of going through perimenopause is to do with your periods. And actually, whether you're on the coil or whether you're a woman that doesn't have regular periods, how do you know that you're entering that next stage then? And I bring up the Marina coil in particular because one of the questions was, a woman said that she's been on the coil for many years and only recently has she been experiencing cramping that she's never had before. So is this cramping a sign that her hormones are changing and she's entering that next stage? Dr. Sharma, would you be able to help with
Yeah,
that
I
one?
think, yeah, I think for those people who don't know what a Mirena coil is, it's a form of contraception, but it also releases progesterone slowly into the system. So when you're going through perimenopause, you've got fluctuating estrogen, which gives you the symptoms, and then you've got this lowering of your progesterone. But if you've got a Mirena coil in there, you've got one of the hormones. It's releasing it nice and steadily, and so women have kind of, I would say, milder symptoms. Well, they won't have the symptoms of bleeding because unless someone's bleeding on the Mirena coil, but so you're missing out on that information that you may get that your periods are changing, or anyone who's on some kind of contraception, they may not realize that because that symptoms mask. So they will get much more estrogen fluctuation symptoms as they're going to head through perimenopause, but they may be much milder. But I think it's again just looking at your body, looking at what symptoms changing. Specifically, cramping with a coil, I wouldn't put that down just to menopause, perimenopause. I would want to investigate that. Obviously, with any coil that you've got pain, may need a scan. It may have moved, it may have slipped slightly, or it may have come out even. I don't know. So for me, I would not specifically that symptom, but looking for things like hot flushes, mood changes, um, joint pains, other things. Just looking at other symptoms that we mentioned before.
Okay, well, thank you. We're going to talk about menopause post-cancer now. And as I said a bit earlier, this is a topic that it affects vast numbers of women, but it is not talked about at all. And I've had quite a few questions coming in, some of which are very specific, obviously, to the type of cancer that these women have had. Um, Dr. Wright, could you start by giving us, it's called a crash menopause, from my understanding. And can you tell us why is it called a crash menopause, and how is that different to a natural menopause?
So I think this phrase got coined during a Maggie's campaign, didn't it? So Angela and I, as part of Spice Pear, joined up with Maggie's centres to try and address this and create a resource for women that are going through this form of menopause. Because at the beginning of all of this menopause revolution, there was a group that was kind of not being talked about, which were the women that were unable to access HRT, that had other health issues that were going through. And the reason that I think they coined the phrase is because rather than going through the fluctuations over multiple years of your ovaries starting to fail as you go towards menopause, women who have a cancer-induced menopause have an abrupt and sudden change in their hormone levels. So think chemotherapy can induce menopause because it sort of stuns the ovaries into being quiet. Radiotherapy can damage them. Surgery will take them away. We use hormone blockers in some cancers, which stop the ovaries from working. So not only do you have an abrupt onset of the hormone change, which we know from the data is often more symptomatic and problematic for patients, you're also suffering that in the context of the sort of hellscape of what's going on with a diagnosis of cancer, that period of being taken out of your everyday life, having to go into treatment, the inherent trauma of an existential threatening diagnosis, and the bodily intrusion of the treatment process. And again, we know that trauma makes menopausal symptoms worse. So this is a specific group of women who are quieter and sort of are less addressed by the mainstream, but are actually having a particularly difficult menopause with less options for treatment, and kind of need more arms wrapped around them, in my view, or our view. So it's really nice to see some of the focus starting to fall on how we properly address not just the symptoms, but also longer term health implications of hormone deprivation in these women. And when we did the research with Maggie's, we started asking the women that came to their workshops, which are free incidentally and can be accessed by any woman listening to this by contacting their local Maggie centre, and their 2-hour workshops online or in person, usually with if it's online, it'll have the involvement of either Angela or I, but the centre heads are involved as well. We asked them afterwards what it was like going through menopause, were they told whether to expect the symptoms, and had they had any help. And we found that over half of them hadn't been told to expect that they were going to go into menopause, that most of them didn't know that help was available. They didn't want to bother anybody because they felt bad about complaining about this symptom when they'd gone through everything, or had perhaps, been treated successfully for cancer. And then how can you complain about your menopause symptoms? They felt like they couldn't. So, there's a huge need to talk more about this and address more help specifically to this
I
group.
think I just add one thing there. One of the things that we heard and hear constantly in these workshops is that the women tell us that the menopause symptoms are worse than their cancer treatment. And
This
that
is
for
my
me is
exact question.
really, really
Yeah.
shocking. Yeah, it's really upsetting. It's really shocking. And the fact that they have these symptoms, and when they go maybe to their GP, they just get told, well, there's nothing you can do about it. And they'll go to the oncologist, and oncologist will say, well, it's not my area, which you understand because they're there to treat the cancer. So these women get lost. They've got nowhere to go really, and no one to talk to. So that's why knowing about these Maggie's workshops, and knowing that there is a place they can go to, and it's free, and all these Maggie centres are amazing because they've got all these other workshops or other support services for women going through cancer. And I think there's about 26 throughout the whole of the UK, Scotland as well. And just wherever you go, you'll find that somebody will be doing a menopause workshop. And
That's
if you're
fabulous.
in
I'll
Leeds, I
I'll
think
put
you can go and see Dr. Wright, or if you're in London in Charing Cross, then you can come and see me. We do them
I'll
remotely.
put a link to Maggie's in the show notes as well,
Yeah, that would be
obviously.
very helpful. Yeah, I think it's something
But
we're really proud of, to
yeah,
some of the work that we've done, and because
We have
it's really making a difference.
it's a
it's
voluntary
phenomenal.
arm to the clinic, and it's been something that we've both been really sort of passionate about, giving back as well as providing the private clinic.
Well, it's devastating, isn't it? Just to recap what you just said, that these women have gone through the trauma and the pain of cancer. And then the question that came through from this woman, she said it wasn't the chemo or the surgery, it was the hormone therapy. She's taking Zoladex and tamoxifen, and it really affected her mood and her emotions. And she said it hit her so hard, and no one prepared her for it. So why do these hormone blockers make such an impact when people have been through cancer? Dr. Wright, do you want to go for that one?
Yeah. So what you have with the combination that lady's on in particular is you have the Zoladex, which is effectively stopping the ovaries from working. So it puts them on pause, for want of a better word. So you don't ovulate, so you don't produce the hormones that you normally do in your menstrual cycles. On top of that, if you're on tamoxifen, you're blocking the action of estrogen in some of the tissues in your body, particularly breast tissue. It sort of blocks what estrogen may do, because you do make a little bit of extra estrogen in your body fat, and you have hormones produced by your adrenals. So there is some sort of excess activity that doesn't just come from the ovaries. If you go on to aromatase inhibitors, so drugs like exemestane, or arimidex, or anastrozole is another name, or letrozole, they block the creation of estrogen in your body fat. So they literally take you from having a little bit, the most postmenopausal women have a little bit of estrogen going around their system, a weaker form of estrogen than the type that they had in their fertile years. But cancer induced menopause patients have significantly less or virtually none. So I've had women, I'm sure Angela has as well in the workshops, who already went through menopause, got their diagnosis, then went on to hormone blockers post diagnosis, and went through menopause again,
Oh
Oh my
my
because
gosh,
they
gosh.
kind
yeah.
of went down another notch in
Oh my
terms of
gosh.
what they're experiencing.
Mm.
And to Angela's point, where she said, you go to the GP and they don't know what to do with you, most doctors are really scared after a patient's had cancer and there's been an oncologist involved, that they're not allowed to do anything. So they kind of
Yeah.
sit back and say, oh, I'm not really sure, So and the oncologists aren't trained in this area in particular. So the other difficulty is that you fall through the net with nobody really feeling like it's their remit to deal with this symptom burden,
Yeah.
even though there are options that can make it better.
Yeah, absolutely. Um, Dr. Sharma, I want to just throw another question out there as well, and I think it's to do with the same woman who, correct me if I'm pronouncing it wrong, ER plus breast cancer, and to do with vaginal estrogen. She's received really mixed messaging from doctors and leaflets about whether it's safe or not. Could you give some clarity on that?
Yeah, there's been some recent guidance about this, and all the Royal Colleges have got together and advised about how to manage menopause after cancer, and
Hmm.
specifically what they say about, I mean, just first to put it into context, that women who are going through this kind of menopause after cancer, they will have really, some of them have really significant vaginal symptoms. And if anyone's ever had them, they can be really debilitating. They can consume you, because of the pain or the itching or the bladder symptoms. And and it's one of those symptoms, that it's really difficult to go and talk to your doctor about. It's really embarrassing, and it's hard to raise as a subject. So most women just suffer with it. So it's important to know who can and can't have treatment. So generally, they say that the vaginal estrogen is safe, but there's some specifics. So if you are having, because it just stays locally in that area, but if you've had breast cancer and what they recommend is that you be on tamoxifen, and then that blocks any estrogen. That tiny bit, if any tiny bit gets absorbed, then it gets blocked by the tamoxifen, because the tamoxifen blocks the receptors in the breast. So it helps to stop that estrogen getting to the breast. If you're on something like letrozole or anastrozole, or some of these other newer medications, then some of the studies at the moment have given a positive view that it is safe, but there's not enough data at the moment. So it's not that you can't have it, but it's something that they
Yeah.
recommend, that it should be based on an individual basis, and it should be something that you discuss with your oncologist. And every woman, again, is going to be different. Every woman has a different type of breast cancer, different expressions of
Mm.
receptors and number of receptors, and where it is and how big it is. And so even in breast cancer, you'll see that every woman is treated differently. You can't like match treatments like, oh, this is what's going to happen to you. So I never say that to any woman. I say you just have to go there to do all these tests, and they'll tell you,
Yeah.
how they're going to manage it. But if you're someone going through it and you've got any vaginal symptoms, I think, again, like Angela said, those GPs are not going to be initiating anything. They're going to be terrified about it. So you have to start with the oncologist.
Okay.
and have that open, frank discussion with them, and again tell them how much it's impacting you. And sometimes even, it might help to take the latest guidelines as well. So maybe you can attach the latest guidelines in your link as well for women to print out, have a read themselves, and then that's a much easier way to approach a doctor. Because maybe sometimes some of the gynecologists may not have been completely up to date with this area as well. So at least if you can show that you've read about it and then this is the latest, then they can go away and read it as well. But some of the terminology, it has been left a bit vague because there's no right or wrong, because it's something that you need to go and talk to your own oncologist about.
The guidelines for the two guidelines that I come back to the most on this are the British Society of Sexual Medicine's consensus statement on genitourinary syndrome of menopause. There's the guidelines that Angela referred to, which are the British Gynecological Society guidelines around looking after gynae cancers. And then the other sort of controversy, I suppose, at the moment is that the American College of Obs and Gynae have released some guidelines in America that are more positive around using vaginal estrogens in women who are on aromatase inhibitors. So I often share those with the oncologist when I'm having a conversation with those women, just to sort of say, look, we're moving towards an environment where we know that this is likely to be, given the burden, the symptom burden and the impact of this for some women. And again, there's that individuality of, if you're a woman who wants to ride a horse or ride a bike or have an active sex life, and that's really important in your quality of life, the amount that you weight the benefits of these treatments and what you do with the fact that we've still got a fairly patchy evidence base on the other side of it, but it doesn't appear to be harmful, but we just don't have loads of data saying it's definitely safe. But there was so the American College of Obs and Gynae guidelines are helpful. There's a big systematic review that was done a couple of years ago, about 60,000 patients with breast cancer, that did not show any recurrence rate increase or any death rate increase in those women that had used vaginal estrogens, which is a really helpful piece of data. And there's the Vibra study, which was done on women with aromatase inhibitors specifically, that showed that those women that used a particular medication called Intrarosa, which is Prasterone, a form of almost a precursor for the hormones, they showed benefits on sexual function and no change in the blood level of hormones. So that informs my practice. I tend to use that specifically in those women. But like Angela says, I always write to the oncologist and just make sure that there's no specific reason I can't.
Collagen and berberine also came up as possible supplements. Is that something that you can talk about, Dr. Sharma?
I think, again, every woman that I see will have, before they've got to me, will have tried something.
Yeah.
And I get it. I understand that, before bothering the GP, you want to see if you can help yourself. And the marketing on this area is immense, and you'll be bombarded with these quick fixes for perimenopause. We can just make everything better by taking these supplements. The difficulty is again, do I recommend these? It's difficult for me because I want to see the evidence before I'm saying to someone, yes, absolutely take this, because it can end up spending huge amounts of money on this stuff and not feeling any better. So the evidence that there is a very small amount of evidence, and it's for phytoestrogens and things like soy, red clover, and things like called black cahosh, and other than that, there isn't any evidence for anything else. Having said that, though, absolutely hear about some women taking some stuff and they feel better, and other women taking it and does nothing for them. So I know that everyone's going to use it. So my advice is, go away, do your research, see what you want to try. Just do one thing at a time. Do one thing at a time, and try and be consistent with it. And that's where all of these things fall apart. Like, you buy something, you get excited, you start taking it for a few days, and then you forget, and then you just don't go back to it. But then you may not have tried it for long enough. So I always ask people to try it for at least a month. And if it's not made any difference to your symptoms, you'll clearly see whether it has by then. And just don't waste your money on it. And if the symptoms are getting worse and they're not think about where the evidence is. There's a huge amount of evidence that HRT is going to help you and help manage these symptoms. But not any evidence on any of these other things. So, but if you're not someone who's not going to take HRT, then obviously this is the route that you have to go down, and you have to think about, what am I going to try? What am I going to do? Specifically about berberine, I haven't really heard that as something that my patients are taking. I definitely hear about collagen, ashwagandha, sage, other supplements, mushroom powders. This is kind of the. I mean, I have to say, like a little story here. Even like I'm a menopause specialist, so I know these things. I know the evidence there, but the marketing is so powerful. I made one mistake of pressing a advert about mushroom powder on Facebook once,
Yeah.
and then I was bombarded. I couldn't believe how much, like you said about the menopause,
Mm.
bombarded with every different type. And at some point, it just gave in or something. And I know that it's not going to work, but there I am putting it in my coffee, and I guess it's that brain fog. It's that brain fog symptom. You just want to feel sharper. You want to feel on it, and it's so important for lots of women, especially if you're working. And does it make any difference? No, it makes no difference. So yeah, I got fooled by that, but that's how powerful the marketing is. Collagen powders, yeah, we definitely start to lose collagen when we're aging, and also collagen is important to help make your estrogen's more important to help make your collagen. So collagen's important for your skin, hair, nails, your joints, your tendons, your ligaments, for your bones. So I can see why taking a collagen supplement around this time would help. But again, is there solid evidence? Are there large scale, studies on this, peer reviewed studies? No, there isn't. And there's small studies if you look at them. It's hard to say to someone, yes, go and take it. And also, what I always ask someone, like, if you're taking it, what happens? How long do you take it for? What
Mm.
happens if you stop taking it? Does everything just go back down again? Then, are you trapped on this now, like forever? So it's a good question to ask
It's
yourself, like,
marketing
why are you
versus
taking it?
health, isn't it? It's that
Yeah,
balance of, how much is
yeah,
just very good marketing and how much is
yeah,
actually making an impact.
yeah. And I think the marketing people are winning at the moment, definitely.
Yeah, well, talking about hearing things, and it's not necessarily miscommunication or discommunication. I was hearing something about how if you regularly eat oily fish and legumes, there's been a study into how this can delay the symptoms of perimenopause. Dr. Wright, when it comes to, we talked a bit about the body impact of menopause, when it comes to kind of the mental support that we need during this stage, having the right diet, what can we be doing, if anything, to support, delay, enhance kind of what we need to be adding to our body at this stage?
It's a good question. I mean, like Angela says, the problem is, if you understand medical evidence, and it's a really dull subject that we were forced through at med school, and there's a book that everybody reads about, how to critically appraise papers. In medicine, we have a hierarchy of evidence, and a single study will come out, and that's enough to get a headline, enough to get clickbait, enough to go into a paper or a blog post or something on the internet. And it is evidence, but it's only a small study, and it might be flawed. And when you get something into evidence base, which means that medics will recommend it, what we tend to look for is meta-analyses and systematic reviews, which means multiple studies, good quality, designed well, that then are pooled together. And only when you've got these big numbers and you can start to establish causation. So I always say, if you go into the sunshine, read a newspaper and have wear sunglasses, you might be at higher risk of melanoma because you're exposed to sunshine all the time. You could say that newspaper readers get more sun cancer, but actually it's to do with the fact that you're exposing yourself to the sun. And the challenge we have with a lot of studies is it the omega-3 supplement, or is it the demographic of people that can afford the omega-3 supplement that goes through? Is it the fact that they do other things like exercise, or have other lifestyle genetic factors that we're not picking up, that are the thing that make the difference? So when you start to sift through all of the stuff that you see on social media, my best advice is have a critical eye as to where the information's been derived from. And unless it's a placebo-controlled, randomized controlled trial where you give somebody one drug and you give the other people a placebo, you match the groups you give it to, and you do big numbers, it is really, really hard to prove that one thing is the cause of the change you're seeing. So in amongst that caveat, what do you do for brain health? What we know fairly well is that healthy bodies, healthy lifestyles support healthy brains. So eating a diet that's as clean and as close to what we should be eating in terms of what we were evolved to cope with. Usually a Mediterranean diet comes back up every time. Plenty of soluble fats, omega-3 fats, so that we can help to build the right proteins and things within our bodies. not too much ultra processed food and so on, which most of the diets in the UK are really rich in these days because we're busy and we grab things off the shelf that taste good. So a good diet does support good brain health. So does exercise, so does social contact, so does keeping busy, so does continuing to learn. All of these things, and it's the stuff we all know about having a good life and managing stress and eating well and doing well. HRT does have a part within that, but at the moment, our evidence base is not that taking HRT protects you cognitively. There's quite a lot of these little studies that show that maybe in the lab, if you expose brain tissue to XYZ hormone, it's a bit better, or whatever, or in animal studies. But we don't have population studies that are well designed of big enough numbers that we can say with confidence that it helps to protect you against things like dementia. So our approach, I would say, is usually really holistic at Spice Pear. We tend to sort of want to look at everything you're doing overall, make a decision about hormones, and we give the advice that we know has got a decent evidence base behind it, which is address exercise, keep strong, address stress, keep busy, and keep going out and seeing people and connecting, and eat a healthy diet. And most of us would say broadly that's a Mediterranean diet, not masses, not crazy amounts of protein. Everyone wants a quick fix and a quick hack.
Exactly. And
You know,
what about talking about quick fixes potentially? Dr. Sharma, testosterone's been getting a lot of airtime recently. Could you give some background? Why are women taking testosterone?
So testosterone is a female hormone, although a lot of women may not understand that, but our bodies do
Inter-
produce it. It's produced in the adrenal glands, which are these little glands that sit just above the kidneys, and also produced by the ovary as well, and also produced by the postmenopausal ovary. So it continues to produce it. We usually produce 3 times more testosterone than we do estrogen in females' bodies in it when we're younger. And then what happens in our 20s, 30s, it just starts to go down a little bit. And around perimenopause, there's a slight dip. And then postmenopausally, just that dip reverses and you just go back to like a steady level again. So there's no fluctuations, there's no dramatic crash, there's no loss of hormones, and your body's continuing to produce them. So that's really important. It's not your third missing hormone, or
Mm.
and it's not disappearing. It's still there. If you had your adrenal glands removed and your ovaries removed, yes, or just ovaries like people with cancer, yes, you're going to have a drop in your hormone. So those are the people that I would be thinking about. Yes, I'd like to give these women some testosterone. So what testosterone does is it's important for sexual desire. It primes the brain thinking about sex, keeps the whole sexual process going as well. It's important for some of the tissues in the vulval area, and for that good. It starts a process of good blood flow down to the genital area. It's also has some impact in mood, and it has some impact in bone health and muscle strength and energy levels. So the problem is that, are there lots of studies on women taking testosterone, and what the short-term impacts are, what the long-term impacts are, what the benefits are and the risks are? And the answer is very, very, very little. And so
Mm.
the menopause societies from around the world have got together and they have put together a consensus statement. So they've looked at all the studies that we've got so far, and they've said that really testosterone should not be used for any of those other things, but except for hypersexual desire disorder. So that is low libido, but low libido that's causing distress to you. So, we do have some women that go through menopause and they don't want to have sex again, but they're very happy about that. So it's not really for those women, it's for the women that it's struggling and it's
Stressful.
impacting their
Yeah,
relationships. But
completely.
what we always have to do, because we know that low libido is not just what's going on in your body and your hormones, it's also what's going on psychologically, the things that we're saying to
Mm.
ourselves, the religious messages, previous relationships, anxiety, stress, depression, all of these things, plus what's going on in our relationships and our day-to-day lives. All of these things have an impact for libido.
Mm.
So if you're doing a disservice to women if you're just giving them testosterone without asking about these other areas. And what we find is sometimes, like when a woman's given testosterone and they don't feel better on it, or it hasn't improved their sexual relationship or their low libido, then they get very disappointed. They feel like they're broken. So it's maybe because someone's not explored these other areas, and that's usually, we find, it's not just the hormones, it will be something going on in their relationships or psychologically. And I think one of the huge factors, especially around this area, is stress and stress management. And, you have to feel relaxed. You have to be in the moment. You have to be in your body, feeling those sensations. You can't be up here worrying about things, thinking about things. So do we give testosterone? Yes, we do. But there's an appropriate time as well to start it. So the advice is to always make sure a woman has kind of enough estrogen first. And it's just because if you're giving someone who's got very low estrogen testosterone, then in a female body, what happens is your body will convert that testosterone to estrogen to try and kind of increase that level. So you're not really going to get those benefits until that estrogen's up. So yeah, so we try to always make sure someone's on an adequate amount of estrogen. What's an adequate amount? And that, I mean, my way of doing it is, are your symptoms controlled on the amount of estrogen that you have? And if most of your symptoms are under control, but you've still got low libido and you're distressed by it, then I would add in testosterone. But I'd also ask about these other areas. What's going on in your relationship? What's going on psychologically as well?
I
Also, I mean, there's so much more. I could do a whole hour's lecture about testosterone, but it is fairly safe stuff. There are obviously some side effects, but if you take it within the dose that you're advised and don't overuse it, you'll tend to be okay. And we're not kind of titrating that level up to a certain level. We're just trying to give you, this is a standard dose, stick with it, and it will keep you in that female physiological range. If you start overusing it, you'll end up in much higher doses, and that's when I see women having side effects. But women always ask about it first now these days. They want to know that right at the beginning of the conversation, which is the change that I've seen.
Yeah.
Before it would be something that I would be maybe suggesting to someone, and now it's like, well, what about testosterone right from the beginning?
Funny.
So just helping to understand that, and not saying no. I'm not saying no, but it is an appropriate place for it to be.
Absolutely.
And explaining to women why, then they're completely on board with that then.
Right, I want to finish up with talking about sex during midlife, but before I do that, just one question. I don't know if it's going to be quick or not, but it's to do with PMDD, and that stands for premenstrual dysphoric disorder. And a question has come through because women experience PMS, but there has been some that have got in touch to say that they experience PMDD, and it's absolutely debilitating. And do these symptoms get worse because of perimenopause? Dr. Wright, could you give a bit more of an insight about, PMS and PMDD?
Yeah, I'll pause my thoughts on sex for a second.
Yes, please do. I will come to you. I promise you, I will come to you.
Yes, it does. We know that the further you are through your reproductive life, so PMDD can start at any point randomly. That we don't really know why. Actually, sometimes women will just suddenly start it at some point in life. Some will have it lifelong. Some can start it maybe after a pregnancy or at another point. Generally speaking, the intensity of mood change increases as you get towards perimenopause. The group of women who've been hormone sensitive previously, so maybe postnatal depression, maybe sensitivity with hormonal contraception, or maybe PMS picture, PMDD picture, they are more likely to have problems with mental health as they go through perimenopause, because the thing that they're sensitive to starts to go really skew-if. And also they have more of a challenge getting the right HRT because they might be sensitive to the progestogen component or the estrogen level actually in what they're being prescribed. So if you have a history of having noticed that you have mood sensitivity relating to hormones, natural, synthetic, pick a specialist to see who understands that relationship, because otherwise you might end up with more problems as somebody attempts to treat you. It's really hard.
Okay.
We do a lot of this at Spice Pear, really hard medicine, because the individual sensitivity differs between women. It's like an umbrella diagnosis to say someone has a premenstrual disorder, if you like. I hate the word disorder, but those women that sort of sit under that umbrella, for some of them it's a specific progestin, for some of them it's the whole luteal phase, for some of them it's just the last few days, some of them it's the estrogen peak. So you need somebody that can zero in, and you have to keep iterating. It's not a one-hit wonder. We're often tweaking, but yeah, it can be suicide. The suicide stories you hear about, I think if you went through the notes, you'd find a postnatal depression, a mood change with a hormone, a missed history of PMS in most of those women. It's it's usually starts in the 2 or 3 years before you get the period changes and the hot flushes. So you often get this prodrome of feeling like you're spinning off and don't really know why. And
Mm.
it's only later that you go, oh, I think I might be in menopause because these things change. So if you've got that history, be aware that for most women, late 30s, early 40s even might be the start of it becoming difficult. And they are the group who may benefit from early hormone manipulation
Mm.
because leveling it out, getting the right levels can be life changing.
That's really good to know. Like you say, people have that slight forewarning of what is to come if they've had the symptoms, like you said, are
Yeah.
postnatal. They can maybe just prepare themselves or research into that area about what could
They
come in a
know
few years' time.
because they avoid hormones. These are the women that come in and say, I don't want to go on the pill. You know, they don't, they ask for the copper coil. They know that they spin off with these hormones. And as Angela said earlier in the podcast, women know that we've been managing this stuff since the year dot. We know our bodies and we know when
Yeah,
something's up.
yeah,
So I think just, yeah, hang on to that awareness of yourself.
yeah. Listen to your instincts. Absolutely. Right, let's talk sex. So, Dr. Wright, we're gonna come to you first. 'Cause I think this is a topic like crash menopause, sex during midlife, perimenopause, menopause. It's not discussed, whether that's because people are embarrassed or whether it's just not out there enough. So let's put it out there. Low libido, pain, discomfort. Why are we experiencing those during our late 40s, early 50s?
So I'm going to use this to link to what Angela said, which is why people ask us for testosterone first. I think testosterone is the first legitimate thing we've been given as women that allows us to go to our doctors and say, look, sex is difficult. And so I
Interesting.
think almost everybody, it's like Viagra with men, suddenly opened a floodgate. I think particularly midlife women, but what we know from the literature is women generally, we have less of a focus on their pleasure in terms of our social discourse,
Mhm.
our religious scripts, everything is less focused. And so is the medical profession on women's pleasure. And a lot of women have historically put up with slightly boring, slightly uninspiring sex, sometimes a bit painful, but you've got to do it because the man's got a need in these scripts that we all absorb.
Yeah.
So I think a lot of people not everybody, but a lot of people have struggled with sex for a while, one way or another. And this is sometimes a legitimate reason now to come and talk to somebody about it because we think something can be done. We look for a quick fix. We hope that
Sure.
testosterone is going to be that quick fix. So what Angela and I are both trained in sexology, and what that does is it gives you what's called a biopsychosocial lens. It tells you to look at what's happening in the body, look at what's happening in someone's psychology and identity and mind, and look at what's happening in their relationship and world and the world they grew up in, that context that's behind,
Mm.
and stick all of that together. So at menopause, if you just take natural menopause, I hate using that word, but that's sort of the classic midlife menopause, the loss of estrogen will affect your body. So it affects the tool that you use to receive pleasure. It affects tissue stretch and lubrication. So it can make pain practically difficult. That makes sex
Yeah.
practically difficult because you don't
Mhm.
lubricate, it's painful. The space gets smaller. It can make it harder to reach orgasm. It can change your brain so that you don't respond in the same way to initiation and sexual cues. You might read a sexy book and go, don't care, I'd rather read a gardening manual. And women,
Yeah.
and there are some women, we have this idea that women don't like sex, but actually what I hear more often from women is sort of I miss that part of myself. It used to be important in my relationship, that identity. I miss that strutty bit of me that occasionally felt sexy, and I don't feel that anymore. And even though
Mm.
my partner says I'm sexy, I don't think I'm sexy.
Yeah.
So I don't want to take myself into that scenario because I'm kind of feeling awful about myself, or it might be a problem. So the biggest thing to do about sex, because we don't talk about it, and because even when we are talking about it in the context of menopause, we're just making it about testosterone. We're not talking about
Okay.
the broader setting of what goes on, is to be really forensic in understanding what's changed. How much of it is about your body responsiveness or problems, negative things you might have as a result of trying. So maybe a UTI or the feeling that you need to pee constantly if you bothered to have sex, or you're having sex and all you can think about is the fact that you're not lubricating and what that means to
Mm.
your partner, who may now think they don't turn you on, and you're sort of sat
Exactly.
there, oh God, is it that puts you off it? Is it how you feel about your body because our skin changes, our hair changes? Is it difficult for you to feel good about yourself? Is it that you're stressed and distracted and there's no space in your brain anymore because, your mum needs help, your work's gone to pieces, the children are going through exams? What you really want is to lie down for an hour with nobody talking to you, and maybe
Leave me
for a
alone.
week, maybe, I often say to women,
Yes.
I can send you to the Maldives for 2 weeks, and the first week you do nothing but sleep, rest, and have,
Yeah.
massages and
Yeah.
good food. In the second week, I send you someone like Bradley Cooper, who's only going to touch you in the way that you want him to, with no expectation. Then would you
I'm
have
on
a look
that
in the
plane
boat?
already.
Exactly. So it's being forensic about it, and if your partner's difficult and you're frustrated with them and you're not communicating and they're nudging you at 3 in the morning, and you used to be okay with that because it didn't have any real negative consequence for you, but now actually it does. There are different things to treat. That's my thing. And to Angela's conversation, which is absolutely right about testosterone. All doctors have different views on this. My personal view is that we're now gatekeeping testosterone too much because, again, of the social media narrative, which is going, everybody needs it, everyone needs it for this, that, and the other. And so now we're gatekeeping a bit much because it's been oversimplified, and
Yeah.
the national bodies have kind of gone, right, these are the people that need it, so here are the guidelines. My view is, if I deal with a lot of women struggling with sex, I'll offer most of them a trial of testosterone.
Okay.
Half of them will stop it because it didn't help.
Yeah.
Women are
Okay.
sensible, they just don't take stuff they don't need. And then probably a decent bunch that none of us really are supposed to talk about will come back and say they felt more alive, more sharp, more energy. We've no evidence for that at the moment, but for some women it does seem to make a big difference, even though the data doesn't suggest it. And I think they're the ones that bang on about it in the media. And actually, if you do feel sharper and you've got more energy, it does help your libido in a roundabout way because you feel better about yourself. You
Mm,
feel confident
yeah.
again. You want to go out and do things like go out in the evenings. I think we need to ask more questions, gatekeep a little bit less, let women be more sensible about stopping stuff if they don't want it. And estrogen for vaginas, massively, massively, and vulvas, massively important. Estrogen in the body, yes, but the most useful thing I give for women with sex at menopause is vulval and vaginal estrogen. So inside, but
Fabulous.
also outside, over the clitoris, over the labia, over the urethral, the exit of the urethra so they don't get UTIs. Really put the hormones back in those tissues, and that helps a lot.
That's great. So I was going to
Sorry, I've
ask,
got ranting.
obviously.
You always get on a high horse about this subject.
No, it's so important. I was going to ask if it wasn't testosterone, what do you recommend? And you've gone on to answer that. That's fabulous.
And therapy, right? So the thing that we don't
Okay.
talk
Yeah.
about is um, we need context for sex. We need to not be distracted. We need to feel safe, psychologically safe. So the post-cancer women who've been prodded, poked, and felt that their bodies are trying to kill them effectively, and that it's horrendous. That's the lack of safety in body that you have after a diagnosis. And the number of things that you've had to withstand by taking your brain away. If you have a blood test, you look away. If you have chemo, you distance yourself. If somebody examines your breast, you distance yourself to get through the situation. So for those women, often just coming back into your body, feeling it's a safe place is a challenge, let alone
Mm,
expecting pleasure. So, so usually the therapeutic stuff that I talk about is being selfish for the team. That's my favorite new phrase. Okay, so caring for your own needs first and foremost, so that you are rested, your own needs have been met, you feel safe in your body, you feel grounded, and then you might be in a position
mm,
for something else. So we all laughed along with me saying I need an hour on the sofa with no one asking me a question, but that is a universal midlife woman
yeah.
experience. We've cared too much for too long, and there is some data from the research, the psychological research, that says that caring is about the least sexy thing we can do in terms of a partnership. So if we're parenting our partner, caring for everything
Mm,
within the household, we're totally out of that erotic
yeah.
space.
Yeah.
So women have to be self-caring first,
Absolutely.
to think about sex. Most of us do anyway. Not everybody. It's never always or never, but a lot of
Yeah.
women are just burned out at this point.
Absolutely. Um, Dr. Sharma, I'd like to just finish up with you, if that's all right, keeping on the topic of sex. And Dr. Wright's alluded to it in terms of therapy, but how do we have those conversations with our partners when we just don't want sex? And it's not the
Yeah.
excuse of the headaches, it's the pain, it's what they're going through. How do we have those conversations when you're not going to cause conflict? there's not going to be that shame or embarrassment, but so everyone can be on the same page.
I think you've hit the nail on the head there, because that is what talking about sex is for a lot of people. It is embarrassing. There is some shame around it. It is difficult to talk to your partner because everything you say is going to have some kind of impact on the other side, and then vice
Yeah.
versa as well. And it's just such a difficult area to navigate. So I think one of the things that's really important and just to understand as well is about that if something's going on with you physically, mentally, psychologically, if you're not able to communicate that to your partner, then they don't know. They're not mind readers. That's really, really important. And if you don't communicate with them and they also don't communicate with you, so they want to have sex but you push them away, then there may be a lot of rejection, hurt feelings on the other side. My partner doesn't love me, when actually really it's not got nothing to do with that, and it's actually I'm in pain, and I'm not feeling good about myself, and like Angela said, all these other things that are going on in your mind, and you've got these two people that are not communicating properly with each other, and then what happens is intimacy gets affected. You slowly start moving away from your partner, just avoiding sex, avoiding hugging. And the worst is like when I ask women and they're saying they're sleeping in different rooms and they say it's because of my hot flushes, but it always makes me worried. Now we're in separate rooms. So how do you bring that back again? I
Mm.
mean, you absolutely don't always need to go to a psychosexual therapist to go and get that communication build up. You have to pick the right spot.
Yeah.
You can't be distracted by kids. You can't have anything else going on. You have to have a set time to do that. You have to have enough time to do that. Maybe going to a neutral place, not in your own house, somewhere outside. I sometimes find walking side to side next to each other is
Yeah,
really nice, because you're not facing each other,
exactly.
but you can still say things, and the movement helps keep you relaxed. You're in nature, and it's a nice way where you can speak and they can speak, and it's really, really, really important
Mm.
to listen as well.
Yeah.
So say what you need to say, but also listen. And I find, like, if people can do that, then what usually you find is there's a huge sense of relief. Oh,
Yeah.
somebody's talked about it.
Yeah.
And then what you might find on the other side, which you fingers crossed, is that the other person wants to talk about it as well.
Mm.
And then you'll hear the things that they'll say to you: I love you, I don't mind what your body looks like, I'm still find you attractive, happy to work with you, let's see how we can find some
Mm.
solutions. So, and on the other side, then they're understanding what you're going through. But invariably you'll get people that it's difficult on your side, it's difficult with your partner because your partner's not that made that way, or that's not how they think, or difficult in the relationship already, which may already have been there, and now it's all going to be raised even
Mm.
more. So this is where I would strongly, strongly advise someone to go to a psychosexual therapist.
Sure.
I think that sometimes it can be so life changing, because
Yeah.
you'll learn about yourself, you'll learn about your partner, you'll learn how to communicate with your partner, things that we never really talked about. We just kind of muddle through life how we do it. But what they're trying to do is they're trying to help you communicate again
Yeah.
in
Sure.
that safe place to talk about these things. And they're trying to help you rebuild that relationship,
Yeah.
rebuild that trust, rebuild that communication. And then they're going to give you the tools and techniques, the psychosexual tools and techniques, to help you reignite that relationship as well. And
Absolutely.
and I think there's a lot of exercises that you can do. Sometimes just going right back to the beginning, sensate focus exercises, where you're just taking sex off the table, penetrative sex anyway, and you're just going back to touch and sensation
Mm. Yeah.
and that communication. Some kind of tantric exercises as well, where you're just communicating without words, but just looking at each other, sense, and that sensual touch as well. So there's lots of different exercises, and a lot of the exercises are based in mindfulness and about going back to your senses and getting
Fabulous.
out of your head and getting back into the body. And I think everyone's individual, and the psychosexual therapist will find the right exercises or the right things to say or the right things to help you as a couple, and it can be life changing. And sometimes
Mm.
actually it can make it absolutely clear to you that this is the relationship I want to stay in, and this is how I
Mm.
want to build on it, and we'll get better and things will get fixed. But it can also be that space where you can be absolutely clear that actually this is not the right relationship for me.
Mm.
This is not the right person for me. And sometimes, people go into these things and they do break up, but you will be in the right place to make
That's
that
very.
decision, and you'll be supported.
I
So
imagine
don't.
it's yeah,
Everyone gets nervous in pushing it away from having that kind of therapy, but Andrew and I know some amazing, amazing psychosexual therapists, and the work that they do is just so
yeah,
transformative. And they're not just looking at the sexual side; they'll look at everything
yeah,
that's going on, and not just for you, but also for your partner. And even if your partner doesn't want to come, just going on your own and having a little bit of therapy like that can be really transformative. Helps you understand yourself,
yeah.
and then you
Well,
may be able to communicate better with your partner.
I imagine it's liberating on so many levels. Like you said, it's not just
Yeah,
about your relationship, but as you learn about your own self needs and self worth as well. Absolutely. I want to thank you both so much for this morning. You have shared an incredible amount of information, and I'm going to put the links to Spice Pear Health in the show notes. We need you on speed dial, basically, so everyone can get in touch with you about everything. But thank you so much, and thank you also to everyone who sent in the questions as well. As we've been talking through them all, they're very varied.
questions. Yeah,
They're very personal, and we really appreciate people being so honest and vulnerable with us in those areas as well. So thank you. But Dr. Sharma and Dr. Wright, thank you so much for your time today.
thank you for having us.
Pleasure. Thank you.
It's been good.